We all know about hashtags, right? There are two hashtags you need to know about. Hashtag NJFP is one. The other is a hashtag that floats around the family medicine community called FM Revolution. So repeat after me. Family Medicine Revolution. Family Medicine Revolution. You're all allowed to feel good about yourselves. Now, I have the pleasure of welcoming all of you this morning to our Frank Snope keynote lecture. This was renamed for Dr. Snope about 4 or 5 years ago. To my right, for those of you who are or have been or may at some point be elected or selected as a Family Physician of the Year, this is the award we used to give out for Family Physician of the Year. You can't have this award anymore. It's much smaller now. It doesn't mean that the award is less important. It means we're much more frugal. But this award was given to Dr. Snope in, I forget the year, and of course it's not going to be on it, 1989. This was given to Dr. Snope in 1989. Most of you know who Dr. Snope is. Dr. Snope is widely considered one of the founding fathers of family medicine, not only in New Jersey, but across the entire country. I am honored that Dr. Snope continues to stay engaged with the Academy from time to time and speaks with us. Most recently, and this is a nice segue, Dr. Snope sent me an email when he completed the membership survey that I know you have all completed. If you did not complete the membership survey, there may still be time, I'm just saying. But Dr. Snope sent me a note and said, I completed the survey. So I was very happy to hear from Dr. Snope. And this entire lecture is as a thank you to Dr. Snope for everything he did for the Academy and for the specialty. I also have the pleasure of making all of you aware of the work that was done yesterday at the House of Delegates. At the House of Delegates, you elected your new officers and trustees. And if any of you are in the room as I call your name, please stand and be recognized. We can recognize all of them at the end of the reading of all their names. You elected as president-elect, so next year's president, not this coming year's president, but next year's president, Dr. Lauren Carruth. You elected as vice president, Dr. Maria Simonelli. You elected as treasurer, Dr. Michael Cascarina, and as secretary, Dr. Kelly Ussery-Cronhouse. You elected 3 trustees to the board, Donna Comiskey, Anthony Michio, and Jeff Rosenberg. You elected a new physician to the board, a new physician defined as a physician who is out of residency for 1 to 7 years, and that's Dr. Jacqueline Yassif. We, the residents last night, just before their Knowledge Bowl, elected Alyssa Resnikoff, MD, as their junior trustee. You elected 2 members to the AAFP delegation. As delegate, Dr. Mary Campagnolo, and as alternate delegate, Dr. Terry Schonbaum. And I believe right over there, not elected, but coronated this evening, Dr. Peter Carazon, our president for the coming year. So congratulations to all of them. If anyone from the Robert Wood Johnson New Brunswick residency is here, stand up. They were victorious last night in the Residents' Knowledge Bowl. Congratulations to all the residents who participated, but especially to the Robert Wood Johnson program. They will leave with the coveted Knowledge Bowl Cup. Now, my pleasure is to introduce Dr. John Cullen, who I have had the pleasure of knowing for quite some time. I have to do some housework first. So we'll read you his bio. It's lengthy. It's lengthy. Dr. John Cullen is a family physician in Valdez, Alaska. Comes to us by way of San Diego and Arizona, but Valdez, Alaska. He's a member of the Board of Directors of the American Academy of Family Physicians, and as an AAFP board member, Dr. Cullen advocates on behalf of all of you, family physicians, and patients nationwide to inspire positive change in the U.S. healthcare system. We could use some of that. Dr. Cullen has practiced the full scope of family medicine in a rural community of 4,000 people. I don't think there's a community of 4,000 people in all of New Jersey. It's bigger everywhere. He's done that in Alaska for the past 21 years. Dr. Cullen works in a small group practice and is both chief of staff and director of emergency medical services at Providence Valdez Medical Center.
I am required to read you the disclosure of the conflict of interest. Dr. Cullen has indicated that he has a diversified portfolio in stocks, none of which have any bearing on his presentation. He has also disclosed that he is a partner in Valdez Medical Clinic, LLC. All conflicts have been resolved through NJAFP policy. With that, I get to go away, and Dr. Cullen.
Thanks, Ray. All right. Well, I'm really glad to be here in New Jersey. I really wanted to come to your meeting even from years ago. I do come from a very small town. We're about 350 miles away from the nearest metropolitan area. So it's 4 family physicians, that's it. It's an area about the size of Ohio. In that we've got about 6,000 people and maybe 100,000 bears. I'm going to talk a bit about empathy, burnout, and resiliency, and also just talk a little bit about what's happening nationally briefly, although I'd be happy to answer any questions. But we did cover a lot of that yesterday as well. I don't know how well that shows up on the screen, but those are the northern lights, and we see these on a regular basis. And we actually sit in our hot tub and just sort of watch them. It's a hard life that somebody's got to do it. But what's really, really cool about northern lights is that here's something that is, scientifically we know exactly what's going on. It's the solar wind interacting with our magnetic field and then interacting with the atmosphere, and then that creates this light display. On the other hand, it's incredibly beautiful. And you can sit there and watch these. They shimmer. There's all these parallel lines, and it's a very dynamic thing. And a still picture just doesn't do it justice because it's ongoing and it's going across the entire sky all at the same time. And I came up for this talk actually because of a couple of really hard experiences. I had a patient of mine die in our hospital. This is a big deal in a community of 4,000. So this is somebody that everybody knows. And so this was after this very intense day trying to stabilize this person and then going outside and seeing this Northern Lights display. And that's kind of what was the impetus of this whole talk. And I should say, too, that the other part of this, and this is, and again, from an academy perspective, is that we really do need to work on burnout issues and to stop that. We lose a lot of physicians to suicide, and it's a tremendous number. I actually lost my partner to suicide about 12 years ago. And so a lot of the reasons why I'm involved in the academy is to work on that. That's really was the impetus to really drive forward. And so not only am I working on my clinic, but I'm also doing things at a national level with the board of directors. So our brains are really wired to promote empathy. This is a legacy that we have had for as a result of being social animals, for the last however many millions of years. And it's really interesting that our brains are really allow us to almost read each other's minds just through facial expressions, tone, things of that sort. And we can predict the emotional states of others. And we have had a lot of scientific advance in this and in empathy recently. As a family physician, I realized that I use empathy as a diagnostic tool. How many people have walked into an exam room and within seconds known exactly what's going on? And this is a common thing. I mean, I walked into a room with a 4-year-old and I knew that she had cancer within about 3 or 4 seconds. And the whole rest of the time of the visit, I was trying to figure out what made me come to that conclusion and ordering the lab test to come to that. But the point is that our brains are really wired to do this, and we don't really understand from a medical point of view exactly why that happens, or at least we haven't spent a lot of time doing it. And so we really look at, we had this development of algorithmic medicine, but there's this empathic type of medicine as well that we use without even realizing that we're doing it. One of the problems we have is that we are subject to aversive behavior, and so when something bad happens, or we have some negative encounters, then we can start to pull away. And if we do that, then we lose that sense of empathy that we have with our patients. there's something about empathy that appears to be representative. And I have some studies that show exactly where that's happening in the brain. And the reason why I started thinking about this with the Northern Lights is with Northern Lights, like I said, it's when you're looking at it, you see these parallel lines of light that are all coming down from all sides. That's kind of how the brain works. It's not just one area that's working. There's multiple areas of the brain that are involved. So there was some studies done by a researcher by the name of Rizzoletti in Italy, and he was working with monkeys. And the way this all started was with something called mirror neurons. And what he was doing is he had electrodes in the brains of these monkeys and near Broca's area. And he was studying what would happen when the monkey would reach out and grab a nut. And the idea was that there was like this table and there was a nut that was out in the same place. And he was trying to figure out what neurons were involved in that planning and the reaching and grabbing the nut. And so they were studying this all day long. And they had these electrodes hooked up to a loudspeaker. So every time this area was firing, because these are very fine electrodes, then you would hear it on the loudspeaker, kind of a noise as the monkey was reaching for the nut. So at the end of the day, the way the story goes, at the end of the day, they were cleaning up, and the monkey was still there. The researcher ran over and grabbed the nut to put it away and heard the same noise. And he found out that it didn't really matter whether it was the researcher or the monkey that was reaching for the nut, that exactly the same process was being used. And so what it looks like is if I reach up and get a glass of water, there is a part of your brain that is already interpreting which muscles I'm using just to do this action. Not only that, but trying to interpret what my motivations are going to be. And you'll see it when somebody has something and they drop it, everybody flinches and acts like they're going to do it. And that's because our brains are already interpreting all the movements of what it is to hold that glass. And as I bring it up, there's a part of the brain that's wondering whether or not I'm going to drink. So there's actually a part of your brain that is looking at motivations as well. If I reach over and pick up a rock, there's a part of your brain that is not only looking at all those movements, all those muscles that are involved in that movement, but then what the interpretation of that action is. And mirror neurons, that's something that we look at all the time when we're doing newborn exams. You can identify mirror neurons within hours of birth. You can do the tongue, sticking out your tongue in front of a baby, and the baby will stick its tongue back out at you. Those are mirror neurons in action. Smiling, starting at 2 months or 6 weeks, you can smile at a baby, the baby smiles back, and that's that whole mirror neuron system that's working. I do a thing where I stack cups at a year, and you just do it once, and then the baby can stack the cup just after seeing it one time. And so that's one of the ways that we learn, is we learn from watching the actions of others. We can watch somebody swing a golf club, and we can go out and swing a golf club. We may not be doing it very well, but we've already analyzed what all those actions are, and it allows us to do it. And there's a saying that Homo sapiens was the species that copied. Because that's how we learn, is that we watch somebody do something and then we do one, right? So, see one, do one, teach one. And this is a process that we do unconsciously. It's something that happens, it's just part of our genetic legacy. And I play music, and the way I can think about this is that it's almost like it's like a resonance. So when you're playing music with somebody, you get into a groove, and you're doing exactly the same actions, even though it's two different people. That's me and my daughter, by the way. And if you look at us, we're really doing the same thing. And so there's a part of our brain that is resonating all the time with the actions of people around us. And that's where it's occurring. And this is the mirror neuron system. This is only the system that interprets actions, but it involves the prefrontal cortex, the inferior parietal cortex, the anterior insula, and those were all parts of the brain. So in other words, when they've done studies using functional MRI, those are the areas that light up. And that's how we know that those are the areas. We don't need to use electrodes anymore to study this. We can actually look at it in people to see which part of the brain is being used. And it's not just one area, it's multiple areas. So it's which muscles are being used. Have you ever done this action before? What is the relationship of the person who is doing the action? All these things are happening all at once, and it's all in parallel. And this is all happening below the level of conscious thought, and it is something that is happening all the time. So this is my daughter and son-in-law, who just got married this last year. And so the next step in this story was there's a researcher by the name of Dr. Singer who studied romantic couples. And what she did is she had, it sounds like a great date. They brought in romantic couples into a functional MRI suite. It gets better. So then they shocked one of them, and then put that person in the MRI machine, and then while that person was the subject could see their partner, shock the partner. And what it turned out is that it didn't matter whether it was the person being shocked or the person was watching the romantic partner being shocked. The same parts of the brain were lighting up. That is that it's just like with mirror neurons. There is a part of your brain that is feeling other people's pain. This is something that actually happens. And again, it's multiple parts of the brain that are involved. It's the left anterior insula and the dorsal medial thalamus and the supplemental motor area and the mid-cingulate cortex. And these are all happening all at the same time. And empathy kind of comes into different kinds. There's sort of an affective, perceptive empathy, and that's where you feel somebody's pain. And then there's a cognitive, evaluative empathy, which is, man, that's got to hurt. And we have a whole spectrum of what we feel. And we can, just by looking at somebody, we have a pretty good idea of what they're going through. And so this is an area that works not only for pain, but it works for social isolation, disgust, illness. I mean, there's a whole range of things. And like I say, just looking at this, you have a fairly good idea of what's going on. Or this. And we're social animals. We use facial expressions to figure out what people are feeling. And so when you look at this, there's a part of your brain that is mimicking what that must feel like. And then there's another part of your brain that says, wait a minute, I remember what this guy did. And then that diminishes your affective response. I mean, this is all happening below the level of conscious thought. This is all subconscious stuff that's happening. And like I said, there's an affective perceptual versus a cognitive evaluative. They're different parts of the brain. It's amazing as how much of the brain is used for these functions. And for family medicine, we kind of have to do both, right? We have to feel what people are feeling. That's just part about being a family physician. But we also have to be thinking about what's causing that pain. And so in this particular case, the green is the affective, feeling somebody's pain. The red is the cognitive evaluative, thinking about why that's got to hurt. I think that our spot is in the yellow. That's the overlap. And that's where we not only are feeling people's pain, but we're also thinking about what it is that's causing it. And then with a cognitive empathy, that's, again, thinking about what's got to hurt. You actually do have an autobiographical memory because you think about when you've been hurt in similar ways. And then the prefrontal cortex, that's probably thinking about what it is that's actually happening. And then there's something called emotional contagion. And emotional contagion is, if you've walked into a room, and how do you know if somebody is depressed? because you get depressed. I mean, for me, that's what I do, is I walk out of a room and go, man, I feel depressed. Oh, that must be because he must be really depressed. And it works both ways, right? Because you can go into a room where somebody is depressed and you can bring them up. Or you can walk into a room where somebody is very agitated and you can calm them down. And so there is this resonance that we have with our patients. And this is just something that happens. This is an overly complicated slide, so I'm going to simplify it. It's almost like there's a slider that goes back and forth. And we can, if we're just sitting around with friends enjoying a beer, we go to the emotional contagion, so we're all resonating and feeling that same mood. But if we have to do surgery on somebody, let's say they were going to remove a lump or something like that, we have to inject them with something that's going to sting. We don't want to be feeling their pain at that point. We just want to be thinking about it. I think that family medicine does this probably better than any other specialty, where we can go back and forth. And there's a balance that we need to achieve when we're doing this. Because it's not, we have to do this differently for every patient. Every room that we walk into, we have to not only do this for each patient, but from minute to minute, we have to change where we're at. So let's talk about family medicine. It's an unselected population, and we have stressed patients. Does anybody have patients who are not stressed? I'm just curious. We have a lot of responsibility. I mean, we go in and we see people, and I do a lot of urgent care in my clinic. Sometimes I'm seeing people who have just a chronic cough. Sometimes they have lung cancer. You can't miss those. And so there's a lot of responsibility. We can't let our game down at all at any time. And then right now, we have this loss of control with administration, with payers. And that's, how do you drive a physician crazy? Is you give them all the responsibility and no control. And that's kind of where we're at right now. And then not only that, but we have, in the military they call it VUCA, volatility, uncertainty, complexity, and ambiguity. And that kind of describes exactly where we're at right now. And unfortunately, I hate to say it, but this has gotten a lot worse since the first of the year. And the amount of ambiguity that is going on is certainly affecting my patients. I don't know about yours. Just about whether they're going to have insurance, whether there's just so many issues going on right now. So what's interesting about family physicians is that we have a higher balanced emotional empathy score even from day one. You can retrospectively look at students who go into family medicine and look at what their empathy scores were. And we have a tendency to be more empathetic to begin with. This is men versus women. Women are more empathetic. That's just the way it is. But both for male students and for female students, the ones that score higher in a standard empathy test are more likely to go into primary care and family medicine in particular. But unfortunately, as a result, we also have a fairly high burnout rate. And it probably doesn't show up very well here. But this is us right down here. So we're doing better than urology, for whatever reason. We're actually less burned out than emergency medicine, but we're not as happy about our work-life balance. And this is something that has to change. So are men and women, which one are more burned out? Women are more burned out. We don't know exactly why. Is it because they started off being more empathetic, or is it because they just have a lot more work to do outside of, traditionally women do a lot more roles around the house and dealing with children. It's really unclear as far as what exactly it is. But when we talk about burnout, it's a syndrome that's characterized by a loss of enthusiasm for work, and that's sort of an emotional exhaustion. And then a sense of depersonalization. And when you think about depersonalization, what that means is that you no longer are treating people as people, but you're treating people as things. And you're not really reacting in that empathetic way. And then a low sense of personal fulfillment. What we know is that when physicians are burned out, that they have poorer quality of care. They have greater patient dissatisfaction. They're more likely to be involved in lawsuits. And they have more problems expressing empathy. The flip side, for those physicians who are less burned out and more empathetic, it turns out their patients get better quicker. That's really odd, but they're much less likely to be sued. And they have greater patient satisfaction scores. And this is important to recognize because a lot of us are employed, and administrators need to realize that they need to create a workspace that does not lead to burnout, because then that'll help the system as a whole. But we get into this cycle where there is exhaustion and then emotional contagion. You're working with people who are stressed, they're burned out, or they're stressed, they're tired, they're depressed. We pick up on some of that. With that, we get that depersonalization. It's sort of a withdrawal effect. Or a desensitization. We don't want to continually to get hurt, and so we pull back. But then that leads to negative personal encounters. And then our administrators get on top of us because our patient satisfaction scores aren't very high. There may be some epigenetic things get thrown in there as well, which is really interesting. We're not as efficient. That makes us more exhausted. And it just gets into a cycle. And then, if we look at, again, family medicine is up here as sort of the top of the list. We've seen a significant increase in burnout within the last 4 years. It's gone up by 12%. So the question is why? And I think that EHRs definitely are part of this. And we need to do something about that. And that's something that I'm really involved with nationally, is just trying to get these to work better for us. It occurs to me that one of the reasons is lack of eye contact, because we're not looking at the patients, and that's an important part of empathy. And but I wonder, there's no way to do it. I wish we could do this functional MRI studies where we watch what we do when we're talking with patients and reacting. Because again, we have there is that empathetic sense that we're using in the exam room. And then what happens to that when we switch over to using the EHR? And I have to admit that I think that there may be just completely different parts of the brain that are being used. But I'd love to do that study, but I can't imagine what a functional MRI machine would do to a computer. So do burnout rates differ by age? They do. You're actually much less likely to be burned out after 66. This might be kind of a survival of the fittest. I don't know. But what's interesting is that if it was just the computers, you would expect that younger generations would be much less burned out, and they're not. It's all fairly consistent across the spectrum, which means that it's not just the EHRs. This has to do with the EHRs and how they're interacting with us when we're taking care of people. So, kind of in summary, the family medicine, we're working with this unselected population. We have to interact with people empathetically. We just do. So what's the number one reason why patients are dissatisfied? Because they feel that we're not listening to them and that we're not connecting with them. And so we have to use this, but at the same time, we're using a system that does not promote this. We have administrators who don't recognize what it is that we do. We don't have a really good way of quantifying this, what we do. We're doing a system where it's, family medicine is a full contact career. Since we have this unselected population, we have to separate what's going on from all their diagnoses. So somebody comes in because they're fatigued, right? Does anybody see people with fatigue? So when you see somebody with fatigue, I mean, are they anemic? Are they pregnant? Are they hypothyroid? Are they depressed? Are they fatigued because they're taking care of somebody who has some major disabilities? Are they? I mean, it's just they have cancer. I mean, there's so many possibilities. And when I was on the board, we in one of our meetings we had the developer of Ibm Watson Health come and talk to us. And I don't know if anybody knows about IBM Watson, but it's a sophisticated computer, almost artificial intelligence, that they were setting up to do healthcare. And they thought, well, we want to start off with something easy. Let's do primary care. You haven't heard that one before, right? No. And they couldn't do it. IBM Watson failed at primary care. And the reason is that IBM Watson is an algorithmic-based medicine, and that's not what we do. I mean, we do that. We do evidence-based medicine, but there's another part. And so they were really worried. They thought maybe this whole approach is wrong, and so they did oncology, and they had it done in 2 months. So IBM Watson works as well as an oncologist, and they had that figured out within 2 months. That has implications for other medical specialties. I can tell you they're already doing radiology, they're doing endocrinology, they're doing rheumatology. And those are specialties that fall very nicely within that algorithmic kind of frame. Family medicine doesn't. And that's because there are too many variables. So that's why when we talk about technological innovation, there's always going to be a place for us, because we're the ones who are connecting with the patients. So empathy. You can teach empathy. Dr. Helen Reese is a researcher at Harvard. She does wonderful videos. You can pick them up on YouTube, and some TED Talks about teaching empathy to physicians that have none. And she has a mnemonic, which is empathy, which is nice. And that's, eye contact. That's how we interact with each other. We interact with each other by eye contact. It's absolutely important. And then facial muscles. Just from looking at those pictures earlier, you could see the expressions on those two examples. You knew really what was going on. And so looking at facial muscles is really important. Posture of the patient, whether they're sitting up straight or they just look crumpled down. That's really important. Their affect. And we all kind of have a tendency to write in our EHRs or even just click the button, alert, male or female, no apparent distress. But we should be really looking at what the affect is. And affect is not so much necessarily how they feel, but how we feel when we're interacting with them. Right? If somebody is happy, we're going to feel happy. That's emotional contagion. And so recognizing that you have an emotional response to your patients is a really nice thing to incorporate into your record. The tone of their voice, just how they're talking. Hearing actually is making sure that you're hearing them. And again, that's the main criticism that patients have is for physicians is that they did not hear what I said. They were not listening to me. And so really making that an important thing of listening to your patients. And then the last is just trying to figure out what your response is. And there's a cycle of empathy, just like there is a cycle of burnout. And that is you get positive interactions, and then you get greater connection with your patients, and then you get a lot of personal satisfaction, and that promotes that sense of empathy. And so you can have this cycle that's going on. And I think that we all are in this place of, on one hand, we're having the burnout cycle going one way, and we have this positive empathy cycle going the other way. And the trick is to really promote that so you're feeling, you're feeling good about your interactions and get that satisfaction and even that joy out of practice. So this is where I live. Not right here, but But that's about 10 miles away from my house. So mindfulness, you hear a lot of talk about this, and there's lots of ways to do it. I was talking about emotional contagion, right? We wash our hands in between patients, and we do that so that we're not transferring bacteria or viruses from one patient to the next. But there's this emotional contagion that we have as well, and we carry that from patient to patient. And so it's really important to have some way of breaking that up. And so I actually do a mindfulness exercise every time I'm washing my hands, just to try to reset. It doesn't always work. I had this really difficult emotional case. Had to do a DNC in the morning. It was just very, very tough. And then I went in to see my next patient, and the more I talked to him, the angrier he got. Until finally I just had to excuse myself. I said, I'm really sorry, but this is just not going well. I went into the next patient, and the same thing happened. And so I went to my partner and said, listen, you got to see my patients. I'm just pissing people off. And went outside for a while, and then I came back in, and then it was okay. But it was just like there was something about the way I was presenting myself that was just really upsetting people. And I've seen that happen before. Kind of an aside, I guess, but I was talking about I had this really hard case where I lost one of my patients, and again, it was just a very traumatic event. It was a high schooler, so it was just really tough. In a small town, everybody knows what's going on, and so while we're coding this patient, everybody showed up. The halls were filled with people. It was very intense. It was interesting because when this was all happening, I could tell that this was really going to hurt, and that it would be something I'd be recovering from. The next day, I could not use my electronic record. Couldn't use it for actually 4 or 5 days. It was the weirdest thing. I had this EHR aphasia that took a while to get back into where I could do it. One of the administrators came by and said, John, you need to get your charts done. And I said, if you persist in this is not going to end well. And so having that mindfulness that's going, and then giving yourself some slack, especially when you are going through these intense emotional experiences. And I mean, let's face it, that's where we live, right? We live right on that edge where people are not feeling well, people are dying. We're dealing with families who are dealing with loss. All of those have an emotional impact. And to think that they don't affect you is just to ignore it. It just means that you're not aware that it's happening. And so having this mindfulness, having some tricks to kind of reset yourself is really important. Andrew Weil, who is actually one of he was my academic mentor when I was in medical school, which I'm really feel fortunate about, has breathing exercises that actually work quite well. And the 4, 7, and 8 it's really a simple one. It's just you breathe in for 4 seconds, and then hold your breath for 7, and then breathe out for 8. And that is amazing how much of an impact that has. It takes almost no time. But as you're going from patient to patient, like I say, that this is a really nice technique. All right. So the other one, and I really appreciated that last lecture, actually. I enjoyed that a lot. Agency is feeling like you have some control of your destiny. And like I said, that's one of the things that we've lost over the last few years, just because of the way a lot of us are employed. We're in situations where we don't feel like we have a lot of control. And you have to have that back. As family physicians, you have to have a sense that you are in control of your destiny. And one of the best ways to do that is to get involved in advocacy. So if you're not involved in your state academy, you need to be. You need to be involved either at your local level, at your local clinic level, at the hospital level. This all gives you this sense that you are in control of what's going on. There is nothing that is more cathartic than going and yelling at a legislator. Actually, not yelling, that's not the right word. Talking with one of your legislators. And again, using that sense of empathy, getting them to feel what you're feeling. That's really important. So I would really recommend it. You need to be involved. These are going to be tough times these next few years. There's just no way around it. There's a lot of changes that are going on. And you need to take care of yourselves. And so you need to be involved in your state chapter. That's really, really important. But not only is it important because that's how you guys are going to do well, it's important because it gives you that sense of control over what's happening. And so it's incredibly important to do that. And that's why I've been involved in everything that I've been involved in, is that, again, it was just a result of things that have happened in my community. I started getting involved in the politics, which got me involved in the running of the hospital, which got me involved in my state academy, and now I'm working at a national level, and it's really fun. And not only that, but it is really important. And some of the things that we've got going on, and I shared this with your delegates yesterday, is that one of the things that we're dealing with is just sort of the nature of medicine over the last few years. This is a graph of this is income here, so this is half income here. This is the cost of healthcare. So this is healthcare insurance premiums. The gray line is insurance premiums plus out-of-pocket costs. This was a graph that was described in 2006. And we have not deviated from that graph at all. So right now, what they predicted was that by 2018, that the average medical care costs, out-of-pocket costs plus insurance costs, were going to equal half of the income, the average income. And we're pretty much right there. And then it gets worse from this point on. The ACA did bend this curve a little bit, but when people say that the ACA is responsible for the increase in healthcare costs, that's really not the case. This is something that we've known about ever since 2006, and we really have not been able to bend that curve to a great extent. A lot of this has to do with how many, or what is the investment in primary care within the communities or within the countries. And if you look at countries that have a much greater investment in primary care, they have much cheaper healthcare systems. And that's true with Australia, it's true with Denmark. It's just, if you invest more heavily in primary care, then you get dividends. And that's one thing that we really haven't done in this country. And then the other thing, and this is the last time this slide was updated, was in 2010, is that we've seen this real growth in administration. So if it seems like you have a lot of people who are looking over your shoulder at everything you're doing, it's not your imagination. This is the reality. Right? So this line right here, this is the increase in physicians over the last, until 2010. The red is all the administrators. I think it's actually gone up significantly even from then. And this is a big part of why healthcare is so expensive. So relationships, it's really important. Do you remember in medical school they say first you take care of yourself, then you take care of your family, and then you take care of your patients? And there's a lot of truth to that. You have to maintain your relationships. People who are in relationships have a much lower burnout rate than those without. And so that's something that's really important to maintain. And then stress. It's funny. Who would love to have a job that has no stress? So why'd you go to medical school? I mean, really, we were in medical school because we really enjoyed the stress of doing well academically. And stress is it's sort of a different thing. There's a threat response where you feel like that you're in danger, but there's also a challenge response. That's why we really enjoyed doing well academically. And then there's a tend and befriend response, and that's what we do when there's a stressful circumstance happening from outside, and then we have to band together to deal with that. And so stress is not necessarily a bad thing. And it's a good idea to do things that cause stress. And I would actually encourage you to do things that make you a little bit scared. because there is nothing like doing something that makes you a little bit scared to make yourself feel a whole lot better after it's over. Here, 1 second. So that's already, you know what's coming here. So we have, like I say, we have a lot of bears. And I could just go on about bear stories all day long if you want. But yeah, those are grizzlies. When you see 3 cubs, you know that there's somebody else coming. Yeah, those are the cubs. That's the mama. And what was interesting, as I missed this, is that the mama bear came right up to us, looked us over, and then just kept on going. And the interesting thing about this, too, was that I had actually had a relationship with these bears because when I would go biking, I would run into this family, and I would be I would just talk and sing, and just so that I knew that I was there, and so I think really what it came down to is they came to our yard, and here we are in the hot tub. We're not really wearing anything, and all of a sudden these bears come up to us. We were about the most vulnerable we could have probably been. But she just kind of walked up to us and says, "Oh yeah, I know who you guys are," and they just kept on going. All right. Okay, how do I restart this? Oh, there we go. And then exercise. So when I went through that really tough case, the very next day I went out backcountry skiing. So where we live, we have the best snow in the world. We get people from all over the world to go skiing there. We have really big mountains. We were the site of the World Extreme Ski Championship. I mean, this is world-class skiing. We don't have any ski resorts. And so the only way that we can ski is by climbing up and then skiing down. And it's intense exercise. You're hovering the entire time right at that border between aerobic and anaerobic as you're going up in altitude, usually about 3 to 4 hours. Best exercise there was. And I can't tell you how much better that made me feel after a really traumatic event. And I do that. We go on bike rides. It's really important to exercise. And it's hard because, on one hand, I realize that nobody has time to exercise, and yet it has to be an important part of your life. You just have to do it. And we just don't do well as human beings if we're not exercising. And so it's really more that it's important to do that. And the interesting thing about this study is that this was exercise just twice a week. And I don't think that's enough. You need to be exercising every day. That really helps. And it's not the amount of work, because where I am, we cover the emergency room, we cover the clinic, we're working extended hours. A lot of times you don't get enough sleep. It really comes down to these other factors, whether or not they were feeling more burned out or not. So that's Michelle biking. That's the backcountry skiing. And if you can see there, it looks like she has tire tracks in the bottom of her skis. And those are skins. They're one-way skins. You just strap them on and you can climb up anything. They're just the most amazing technologic advance. And so we walk up and then ski down. And then diet. It's just really important to eat healthy. That's a mindfulness thing. Has anybody read the book, The Blue Zones? It's a great book. There's a lot in there that I wish they wouldn't go into as much detail, and it's really more for the lay public. But what it was is they looked around the world at places where people commonly live over 100. And not only live over 100, but they live over 100 in good health. And these are places, and they're all over the world, but they're in fairly small communities. One of those is Okinawa, and it's women in particular live a long time. They have relationships. They have this relationships that they develop ever since they're teenagers. And then they maintain those relationships. There's even a special word for it, which I don't know. But it's like a kinship group, but they keep the same people together until over 100. They eat healthy. They eat a mostly vegetarian diet with some fish. They exercise. They walk pretty much everywhere they go. But they also have this sense of ikigai, which is it's this intersection between what you love, what you're good at, what the world needs, and how you can make a living. And that sweet spot in the center is your ikigai. And that changes over time. This is a personal journey to figure out what your ikigai is at that moment in time. And it can change. But that is one of those things that seems to help to have that sense of purpose. It does a lot to preventing burnout. And I think lastly, I think it's important to teach. That's something that it makes you much more aware of how you do things. And so we actually bring in students and residents into our house. We have a big house. All the kids have moved out at this point, and just make them a part of the family. And it's really one of the most rewarding things that we do. And so I would really, really strongly recommend it. It's one of those things that there's not enough family medicine preceptors. And so it's an incredibly important thing to do. All right, that's it. So I'd be happy to answer questions about this talk or about anything happening nationally. Okay.
What would you consider to be the biggest drivers of healthcare costs that perhaps you showed earlier? What are the biggest pushers of cost in America?
You know, it's multifactorial. And so prior to the ACA, it was what are the drivers of the healthcare costs increasing like that? And it's complicated because there's multiple drivers. Part of it is the technology, and that we have a lot of medications that are very expensive. Just the cost of medication is a part of it. But when they were looking at the initial graph, it was really looking at technological innovation being a healthcare cost. A lot of it has to do with uncompensated care. Right, so if we have people that have no insurance, a lot of times we'll end up seeing them anyways, right? Or if they can't pay, or if they're in a situation, if they can't see us, then they go to the emergency room at 10 times the cost. All those costs don't disappear; they just get added into those people who have insurance. And so when that happens, then insurance gets more expensive. Fewer people can afford it. That means more people are uninsured, which they still get care because they still need it, and that runs into a cycle that gets out of control. There's other factors, but those are probably the main ones. And so, like I said, the ACA actually bent the curve a bit because it reduced the number of uninsured. That was the entire purpose. That was why we did it. Is that the reason why we did the ACA was we were trying to figure out some way to make sure that everybody had coverage so that we weren't getting into this spiral.
You recommend going back to written chart instead of computers, so we can have like that, understand the way patient goes. So it's long with that, like you need to office. And is this electronic medical record is just copy and paste, just 58 very long.
Well, I think that there's a couple of things in that. The question is what are we going to continue with the EHRs, or maybe we should come up with something better? And we're already talking about what would our professional life look like in a post-EHR world. Because the promise of EHRs has just not living up, has not materialized. Now, part of that was that the people who are developing the EHRs, by and large, were not physicians, and so they were it was a billing platform that they kind of slopped over into some clinical uses. It's gotten a little bit better, but not a lot. And so we need to radically change the way that we do the whole documentation. The other problem we have, though, frankly, is that we're being paid on what we are documenting. And that really should not be the case. And so, and the last lecture was talking about, being careful about the blended payments. The whole idea with that is we want to get to a place where you're not being paid by how much you document. At that point, the copying and pasting really doesn't really matter. And because that's really not good medicine. I get charts from the ER in Anchorage. I send them up, and or they see somebody because they have an ear infection while they're up there, and I get this 27-page note back, and it has all sorts of information. It just doesn't have anything that's all that useful, and it's really, for us, it's dangerous, right? Because there's information in there that we may not find, but which a lawyer may be able to find down the road. And so those are those unknown knowns that we have in our chart that we don't have time to go through all that. So we need to change that, absolutely. And that's sort of the advantage of being paid for quality and looking at outcomes as opposed to being paid on a per visit basis, because at that point you don't have to document so much to get a 214 versus a 213. And there's a lot of things that are happening with that. I have no idea how it's going to end up yet, though.
Use the mic.
Huh?
Use the mic.
Okay.
Yeah, after getting a little burned out myself and enjoying mindfulness meditation, I'm now picking up. I have so many stressed out patients. So part of the office visit, or I make a level 3 into a level 4 visit because I spend time with them. I'm teaching them a type of Tai Chi stress management thing I've been trained in, www.4minutefitness.com. And also I just give them a YouTube of John Kabat-Zinn 10-minute seated mindfulness meditation, and another YouTube or two, and I just send it right to their phones, and they have a tool to have a break. So I think doing office-based, quick, easy stress management is a useful tool for them to cope with their illnesses and their life stressors.
Excellent. I understand that we're out of time, but I will be happy to answer any questions or chat afterwards. You're welcome.
And where'd your mic go?
It's right here.
Oh, yeah.